All right, so we are going to be talking about renal disorder, specifically BPH. So BPH is benign prostatic hyperplasia, and this occurs when the prostate enlarges. We're not 100% sure what causes this, but we do know what happens with the prostate is as it enlarges, it obstructs the urethra, preventing urine from leading to a greater likelihood of UTI and other issues. We do believe that it is in some way related to aging and the presence of androgens. Other risk factors we found include drinking carbonated beverages, family history of bladder cancer, as well as race, specifically African Americans are more likely. We also know obesity and older age is a risk factor. Symptoms we're going to see with this are frequent urination, urination during the night, getting up, hesitancy. It takes a while to get started. They also tend to have urine retention, so they feel like uh, they need to pee immediately after it. They're more likely to develop UTIs. We will also have a negative PSA. PSA is prostate specific antigen. It is a cancer protein necessary for prostate cancer because these same symptoms would be available for prostate cancer. You're not going to be tested on prostate cancer, but we do know for our normal caring, we need to be able to know the difference between benign prostate hyperplasia and prostate cancer because the other symptoms are going to be there. Other symptoms we want to look into are diabetes, hypertension, stroke, and heart attack because these might be associated with other conditions that might be in the background. We also want to look for abdominal pain, scrotal issues, fertility issues, sexual function issues, or UTIs, because again, that could correlate or be related to some underlying issues or things like that. The main thing with this is the greater likelihood of UTIs, as well as the impact to the renal system. We also know if the bladder is full, that is going to lead to pressure that's going to start backing up into the kidneys, what we would call a post-renal issue, leading to a greater likelihood of kidney disorders, kidney disease. So again, we're wanting to figure out what's going on. We're going to do our blood tests. We're going to do ultrasound. We'd be able to see it's larger. Tissue biopsy would be the most accurate. UA, UC, we're looking to see, is it prostate cancer? Is there something wrong with the urethra? Is something wrong with the kidneys? Again, we want to figure out what's going on. Assessment is almost always our first step. So there's two main medications we can give for BPH. We have our 5-alpha reductase inhibitors, such as our finasteride and dutasteride, or we have our alpha blocking agents, which actually decrease the pressure within your urethra, our tamsulosin, also known as Flomax. Our 5-alpha reductase inhibitors is a hormone. It takes about 6 months for it to kick in, which you can understand is going to possibly be an issue. Since it is a hormone, we do not want anyone using it with their bare hands because there are hormonal risks. It can also cause erectile dysfunction issues and libido issues. Our alpha blocking agents are going to decrease the pressure. It helps them pee. It's almost immediate, but it will have the side effect of affecting their blood pressure and can cause orthostatic hypotension. Another fun thing about 5-alpha reductase inhibitors, it does increase the likelihood of gynecomastia in men or male breasts. We need to know about those. Both of these can cause orthostatic hypotension. We're worried about fall precautions as well as blood pressure control. Also, hypertension in African Americans are more common with this, and we know there's a good chance they're already on some blood pressure medicine because of hypertension. Other medical management is our digital rectal exam. This is a relatively non-invasive test. You should not be able to feel the prostate digitally, but that will let you do it. We want to have fluids. One of the big things we'll notice with here is patients are frustrated with the number of times they need to go pee, especially during the night, and start to hold off in fluids because if you don't drink, you won't pee. But that's going to put extra stress on the kidneys, increase the likelihood of kidney disorders, kidney stones. So we want to make sure they're having fluids to keep kidney. Anticholinergics and decongestants are going to dry you up and worsen BPH. And antihypertensives, again, a lot of the medications have a risk factor for orthostatic hypotension, so that's a safety. If none of those work, we have surgical interventions. And then, of course, our post care. So before we talk about surgery, there are some non-pharmacological treatments. Estrogen and androgen have been found to be somewhat helpful, not as helpful as the actual medications, but it has found. Foods high in lycopene, which give foods the red color, such as tomatoes, red grapefruit, and guava have been found. Saw palmetto extract has also been helpful. Be aware saw palmetto extract, since it is a herb, can still interfere with drugs, so we want to be aware of that. Also, interestingly enough, your book talks about there was one study that found frequent sexual intercourse does decrease the likelihood of our BPH, although there hasn't been any additional studies that have shown that. That is something that we might educate our patients about. So, when we talk about medical management, there are non-invasive and invasive. Our non-invasive are usually day of surgery. They will leave the same day, and it decreases the likelihood of severe issues. But we talk about it. I will use the word non-invasive kind of loosely here, so just keep that in mind. So, our transurethral needle ablation, also known as TUNA, they are going to send a metal rod or a wire loop down through the urethra, and it's going to burn the prostate, causing it to shrink. There are some issues that can happen with this, which for our tuna, they can have burning when they urinate for 1 to 2 weeks. They will also need a Foley for 2 to 3 days. The Foley helps reduce the likelihood of inflammation causing blockage of the urethra. Our transurethral microwave therapy, also known as TUMT, can result in they're going to put a wire or an antennae and send microwave energy at the prostate, causing it to be destroyed. They can have burning at the tip of the penis for up to 1 week. It can take several months for the results to happen because it takes time for the body to reabsorb it. It also drastically increases the risk for prostate cancer, so they need to get checked out pretty frequently for digital rectal exams and other tests. Our interstitial laser coagulation is going to use a laser to burn the prostate. They need to have a Foley for a full day. It is also an outpatient procedure. They can also have what's called a retrograde ejaculation, which mean when they do have an orgasm, there's a chance that the semen will actually go back up into the bladder instead of out. And our electrovaporization of the prostate um, is going to be sending a heated ball or wire into there to burn it or vaporize it. You need to be really careful not to strain when they have a bowel movement or urinate, and not lift up anything heavy for several weeks, as there is that possibility of damaging the separation between the urinary system and bowel system. These are all on table 64.2, and you can review them in more detail if you so choose. Yep. There we go. Our TURP is our transurethral resection of the prostate. There is a video where it goes through. This is considered a lot more invasive. We will actually don't know if it will show. It will not on here. They will actually remove the area. Um, I'm sorry. Our TERP is our less invasive option. It's usually our go-to option. They will use a small microsurgery and go through the urethra, and they will shave off pieces of prostate. With this, this is preferred because it's less likely to have infection or other severe issues, but they will need what's called a CBI afterwards, continuous bladder irrigation, because all those pieces of the prostate as well as blood clots need to be removed from the bladder. And we'll talk about that in a couple slides. Our other option is an open prostatectomy, which we almost never do anymore because of the severe risk of infection and other kidney trauma. This would be removing the entire prostate. But to do that, you would need to remove the whole bladder, and that's an invasive surgery, high risk for infection, evisceration, hemorrhaging, bleeding, all of that fun stuff. It also would affect their ability to have normal sex because remember the prostate's whole focus is to create the seminal fluid semen is in. So again, it's almost never used that way specifically. For CBI, continuous bladder irrigation, this is going to happen after a TERP, and instead of a two-way Foley with the balloon and the bag, there's a third lumen. This is also known as a three-way Foley. The third lumen is connected to an irrigation bag. The fluid goes into the bladder, swirls around, and comes out. We would be putting normal saline in. Usually the bags are like 2,000 milliliter bags. And you, the nurse, would be titrating the clamp on the drip chamber. We want the urine that's coming out to be pink lemonade color. Um, if we are giving too much diluent, we can cause what's called TERP syndrome, also known as water intoxication, a life-threatening condition where they are getting way too much fluid and it pretty much dilutes their sodium to a deadly level. If you're not giving enough, it runs the risk of a clot obstructing the urethra, causing fluid to back up, or also internal bleeding. So you, the nurse, would be controlling the amount and balancing and then monitoring. We are going to subtract the irrigation bag from our eyes and nose to make sure they're not holding on to too much fluid or getting rid of too much fluid. This Foley also prevents the inflammation and damage leading to constriction of the urethra. There is a risk of clots in there. That's very normal. And we would not be really concerned if there's clots in the bag, but there is a risk that the clot could obstruct the urinary Foley. If that's the case, the nurse would attempt to remove the clot, usually by attaching a syringe to push and pull the clot until we either remove it or it's pushed away from the Foley opening. If it is fully obstructed and we cannot fix it, we would need to call surgeons and they would need to go back in there. This is not a Foley that's placed by nurses, but one that's placed by the surgeons. Eventually, they will have it removed, but they usually go home with a Foley because of the trauma. And we'll talk about some other safety things. So we got quite a few nursing diagnoses. This is going to affect their urinary function. This is going to affect sleeping and fall risk. There's going to be pain, risk for infection, risk for injury related to either the procedure or the inability to urinate properly. We need to educate our patients on signs and symptoms of infection to monitor for, signs and symptoms of kidney damage, kidney trauma, bladder spasms, internal bleeding, and that TERP syndrome. Again, infection, we want to make sure they're drinking plenty of fluids because we're worried about kidney trauma. We want to strengthen the muscles because they have had difficulty with holding it, and by removing the prostate with open prostatectomy or the TERP, it can actually lead to urinary incontinence because they haven't had to hold or hold on to their urine like there. We're worried about GI issues due to trauma and irritation affecting the bowels as well. We don't want them to strain and possibly pop something. All those lovely things. Again, we want them to know the signs and symptoms of infection, signs and symptoms of kidney disorders, kidney damage. One of the fun things is retrograde ejaculation can happen. Again, when the man orgasms, the semen will actually go back up into the bladder instead of out. We are worried about internal bleeding, infection, even though TURP is less dangerous than an open proctectomy. We are still going into a sterile body part, and we're worried about TURP syndrome. Patients should not be having sex for 4 to 6 weeks after the procedure. We know this is much more common in our older adults and in our African American group. So these are the big things. So the difference between arterial and venous, both are a dangerous thing. Our arterial bleed is going to be bright red. It looks almost like ketchup. Our venous bleed, again, is going to be a dark red. It almost looks like a burgundy or like a red and a brown mixed together, a little bit darker than this. This would be closer to arterial bleed. Both of those need to be reported to the doctor because they need to stop the bleed. Both really bad. Again, infection, retrograde ejaculation, and then TERP syndrome is our water intoxication. Because if you do watch the video that's on your PowerPoint, they do fill up the bladder with water to reduce the likelihood when they are carving the prostate off that they don't actually puncture it, and we're giving them the fluids afterwards. It can cause severe water intoxication or water dilution. Some of the red flag symptoms for TERP syndrome include headache, dizziness, hypertension, and bradycardia, as well as an altered level of consciousness. For our hemorrhaging, need to notify the doctor. If it's arterial, we're going to dilute the solution and notify the doctor. If it's venous, we would monitor H&H. And that is our prostate. And then we're on to